My name is Mike Egang, and I'm the Executive Director of the Rare Access Action Project, or RAAP. And we are an advocacy organization that is a coalition of patient organizations and life sciences stakeholders. And our entire goal and mission is to prepare solutions to rare patient access challenges. And so our panel this afternoon is going to explore not only some of those challenges, but talk about the patient journey and how the patient interfaces with those challenges, and then have a discussion about some of the solutions and things that may be useful in some of the thinking, particularly as we've met with a number of legislators during this sessions, that the Rare Access Action Project and some of our patient partners can offer to find solutions that improve patient access, lower patient out-of-pocket costs, and really can take advantage, particularly in the rare disease space, of rare disease therapies that are rare. So less than 5% of rare disease patients have access to a therapy. And so this is a really important area for us to explore, to find out how we can encourage those solutions getting to the patients in need at the right time in their patient journey. So I want to share with you just a brief agenda, a little bit of an introduction to our organization. We will then introduce our panelists, who I am very excited to be able to be together with this afternoon. And then we'll talk about some of those key issues, potential impact of some of the issues that are being debated at the state level today, and then potential solutions that we hope will offer some solutions to patient access. And then we will end with a wrap-up and a Q&A if we have time. So we'd like to welcome one of our panelists and invite you to come up with the group. We'd like to welcome Brian Patrick Kennedy, the President Pro Tem of the Rhode Island Assembly. He is also the president of the National Conference of State Legislatures. And Representative Kennedy has been a huge champion for rare diseases. By way of background, they had an RDAC, or Rare Disease Advisory Council bill in Rhode Island this year. And we're very excited for that because it brings rare disease patients to the table where they can offer solutions. And so we're very grateful for all your work on those issues, and for his leadership here at NCSL. And then I'd like to introduce Melissa Horn, who's the Director of Legislative Affairs with the Arthritis Foundation, and she's a rare disease patient. And it's been wonderful to work with Melissa because she brings that aspect to a lot of the work that we do. And she has just been an incredible voice, not only for arthritis patients, but for rare disease patients. And then I would like to also introduce Karanette Hinckley, who is a Vice President of State Policy at the ALS Association. And of course, ALS has been a wonderful partner with RAAP on a number of state issues, and we really value their collaboration with us. And we look forward to hearing from her today as well. So by way of introduction, RAAP has been in existence since 2017. We, as I discussed earlier, are a coalition, and so we work very broadly with patient communities, with life sciences organizations, with research and educational organizations, as well as others who are stakeholders, to try and find solutions to the challenges of rare disease patients seeking care and treatment. As many of you know, there are currently about 10,000 identified rare diseases. So I want you to think about how large this unmet medical need actually is. 1 in 10 Americans has a rare disease. So they're your neighbors, they're your friends, they're your kids' soccer coaches, they're leaders. I can't tell you how many state legislators we've met who are either impacted by a rare disease personally or have family or a friend who has a rare disease. And as we had talked about at the beginning, less than 5% of those 10,000 rare diseases have an FDA-approved treatment. So this represents a significant unmet medical need, and one in which there is not only a lot of work left to do on the research, the development, and working with the FDA side, but also working with payers, with state governments, and making sure that patients have access to those therapies when they do reach the marketplace. There we go. So, as many of you know, the pathway for new drug approvals takes a long time. And also resources, some of the most talented people in the life sciences and at universities and family foundations actually work to bring these therapies forward. I've worked in and around the life sciences for most of my adult life, and I can't tell you how many professionals I've met that are either treating at local clinics and working full-time to research a drug. They're providing care. They're involved in local advocacy organizations. They really are getting involved because it's a personal journey for them to try to find these therapies. One thing I would like to point out is that a few years ago, Congress passed the Cures Act. And that has transformed not only the drug development process, but it's transformed the patient advocacy community. Patient advocates are invited now earlier in development. They meet with the scientific teams. They get to understand the therapies, and they are involved with creating disease histories. They are involved with enrolling and encouraging folks to come forward for clinical trials. They're involved with the FDA. I sometimes tell my colleagues, patient advocates with the level of education and sophistication are sometimes the most educated not only on their disease, but on the very therapies that they're involved in. They are a huge resource. But unfortunately, in today's environment, once that product is approved, often patients are told, thank you very much, and here's how you're going to access the drug, without any discussion, any collaboration, and any understanding how those decisions meet with the patient journey and their ability to get the value from that therapy. Of course, the patient journey intersects with policymaking, and nowhere more acutely than at state government. And that's kind of the neat thing about state government. It will take us literally years or maybe a generation to make changes and solutions at the federal level. And yet state policymakers often have open doors. They listen, they try to understand the issues, and they work with the various communities to try and find solutions. And so there are a lot of issues that are currently being debated, talked about, researched into it to be understood better at the state level, and patients are beginning to intersect with those conversations. And so it's really important, for not only patient advocates, but for legislators to really get to know some of those patients and get the value from their experiences and their understanding. And some of the issues that, of course, we have been involved in at RAAP and my colleagues have been involved in at the state level, copay accumulator and maximizer reform, alternative funding programs, which to many is a new kind of way that the risk for certain therapies are shifted into nonprofits and other programs rather than through the insurer or the carrier. And so these have tremendous impact on rare disease patients. Copays, high costs, out-of-pockets. These are areas, again, that acutely affect rare disease patients. Step therapy. Imagine getting a diagnosis for a rare disease and having to step through a therapy that actually won't work for you. And it's well known it won't work for you, but your insurance plan requires you to step through that hoop before you get access to the therapy that will work for you. Risk pooling. Growing the opportunity for specialized programs and plans and coverage that allow more rare disease patients to access lower cost premiums and out-of-pockets. We've been working with a number of states on risk pooling. It's an exciting future area. Of course, Medicaid decision making and linking those patients up with the state professionals who oversee that and the vendor programs that they utilize so that you get a rare disease patient and specialist input during the decision making, not after, but during, so you can make better decisions. And of course, prescription drug affordability boards that we'll talk a little bit about today are kind of like a frontier and a very experimental area that will impact many rare disease patients. And of course, rare disease advisory boards, such as what was being worked on throughout this year in Rhode Island, and bringing those patients to the table, hearing from their voices, and then bringing those learnings inside state government. So again, what I'd like to do at this time, I'd like to turn it over to our panelists to spend a few minutes with you talking about their specific journey, some of the things that they've been working on, the areas that are important as they move issues forward. And you're going to get some very different perspectives because no patient, no legislator is exactly the same. And so we'd like to first turn it over to Representative Kennedy, and then we would like to turn it over to Melissa Horn, and then finally to Kara Nett Hinckley. And we'll go from there, and then we'll have a discussion, and then if we have time left, we'll open it up to questions.
So good afternoon, everyone. Again, I'm Speaker Pro Tem Brian Patrick Kennedy from the state of Rhode Island, and I'm also NCSL President for about an hour and a half more. Yeah. So then I'll become President Emeritus. So state of Rhode Island, we have been looking at a whole host of different things that we can try to do to try to help address this particular situation. Now, we've been looking at the situation with copay accumulators. You can understand that in a state where there's a certain large pharmacy chain that begins with C and ends with S, that may not necessarily be a popular thing to hear in the state of Rhode Island, specifically if we have drug companies that are offering discounts. Quite often, the plans that are offered to the individuals may not necessarily address that situation about those coupons that are supposed to help to buy down the cost of the product, but doesn't count towards your copay share. That is a major problem. We're still trying to address it in the state of Rhode Island, but as I said, that is a very, very difficult challenge for us. We did pass a piece of legislation which I sponsored a couple of years ago, which has been helpful for a number of people, particularly those who require some type of transplant service, or up to this point in time, Rhode Island did not offer the ability for individuals to buy Medicaid or Medicare supplement policies. And essentially what that meant was if you didn't reach the age requirement, you couldn't get one. And if you couldn't get one, and if you needed a transplant, and you didn't have the financial resources on your own to prove that you could help to pay for your share of the transplant, you were taken off the list. So we changed that to address the situation, and now those who are suffering from certain diseases, end-stage renal disease, for example, are eligible to go out and buy these particular supplement insurance policies. And that, we think, is going to be a great step forward. Now, this past legislative session, I introduced the legislation to call for the creation of a rare disease advisory council in the state of Rhode Island. We got a state senator to also introduce the bill. On the Senate side, we were successful. On the House side, I think we passed it unanimously, sent it over to the Senate. Unfortunately, Senate did not move forward with the legislation, and so we will have to reintroduce that legislation next year in 2025. But our ultimate goal is to get that bill moving forward so that we can create this Rare Disease Advisory Council. We think it will be very beneficial within the Department of Health to have these individuals there to help to advise. The question that came up was money regarding the creation of this study commission or the study advisory group. We don't think it's going to be a large amount of money, and the Department of Health is eligible for grants and things such as that. So our ultimate hope is that in 2025 we can finally get that legislation moving forward. In NCSL, we did a thing at the Capitol Forum last year in Austin, Texas, where we spent a day and we brought in legislators as well as staff from across the country in order to look at this particular issue of rare diseases. I think it was a very successful one-day summit, and going forward, I think it's programs like this in the Learning Hub that become very, very helpful to help inform not only our legislative staff, but as well as our state legislators across the country. So with that, I'm going to turn it over. Thank you.
Does this work? Yep. All right, perfect. All right, we're going to go a little casual. I'll just have a conversation with you all about the work that I do for the Arthritis Foundation. So I'm Melissa Horn. I am the State Legislative Affairs Director, so I cover all 50 states. So you'll see me kind of hopping around the nation, working on a lot of the same issues that were already discussed. I serve as the co-chair for the All Copays Count Coalition nationwide, and that is in an effort to ensure that, as the name suggests, all copays count. So if a patient has a medication that is very expensive or maybe even inexpensive, but they're seeking assistance to pay for it, that they're not penalized for that, that copayment, if it's from a foundation or a drug manufacturer, is counted. And I want to be clear too, like, this is not referring to coupons or discounts. Coupons or discounts are really referring to the price of the drug. So let's say you go to the grocery store and you have a coupon for 50 cents off a Snapple. 50 cents off of a Snapple adjusts that price at the point of sale. That is a different conversation than if someone behind you says, hey, I'm going to pay it forward, I'm covering your bill. That's assistance. So that's what we're talking about. We're talking about assistance. So if a foundation, again, or a drug manufacturer says, I'm going to help cover your copay cost for this drug to ensure that you can get coverage for it and fill your prescription and stay stable on that medication, we want to make sure that that counts towards that patient's copay deductible as well as out-of-pocket maximum for the year. Because to us, it's just like getting a scholarship for college. That scholarship is for that patient to pay their tuition bill, and it's for them to count towards their deductible and out-of-pocket max. So that is the predominant focus of the model legislation that we have for the All Copays Count Coalition, and what we've been successful in pushing in 21 states through legislation. And recently, also in Nevada, through regulatory guidance, we actually had a federal court case that had a ruling that came out that said that copays should count, which is what we've been pushing all along. We want to enforce that rule. So we can go through the regulatory route, and we've been working with Department of Insurance in many different states as well. So kind of going at it in two ways. We know that state law change is the ultimate of what we want to codify this more permanently, versus going through the insurance commissioner could vary by administration. We want to make sure it's consistent for patients throughout the country, wherever they live, however they are covered, whatever kind of insurance they have, whether it's employer-sponsored and federally regulated. We have the Help Copays Act on the federal level too. Or if it's something that the state law can protect, that they are covered if they need to use that assistance to pay for their drug. So I know that there's a lot of other states that are pursuing it. We also have DC and Puerto Rico that have laws. I know North Dakota also has some activity coming up this year. We hope to have, the entire nation have that standard, that again, if patients need assistance, they shouldn't be penalized for that, and that should count as a payment for them. So I do have a couple one-pagers if anybody's interested in picking that up, and I know the Rare Access Action Project also has a lot of great information on this topic, but there's more than 80 disease groups. This is not about one specific disease. I myself am a 3-time cancer survivor, and I've had another rare disease that's super rare, where I've had very expensive medications. But again, even the inexpensive ones can be unaffordable. Even if it's like $50, we find that our patient community might abandon that prescription. So if somebody needs $50 or they need $5,000, again, we just want to make sure that they have that access point. The second issue that our foundation works predominantly on across the U.S. is around step therapy. So this is that fail first policy. So a lot of health plans will have this requirement through their utilization management protocols that says, well, we have this drug tier, and you need to try this drug first before you can try the one that your doctor prescribed, which we understand those kind of benefits and why protocols exist. We just don't want them to be overly burdensome if we know that that patient has already failed, for example, on a drug, or has an allergic reaction, or some other barrier where the cost to them physically and financially is not beneficial. We want to be able to go through the appeals process and the exceptions process so the patient can get to the drug that will work best for them. And that really relates to our third big priority for the Arthritis Foundation, which is biomarker testing. We want to get into more precise medicine. So it's not just about diagnosing the disease, it's about making sure that if your body type has like a certain cell composition, that you're not going to react the same to a certain prescription medication or an infusion as someone who has the same diagnosis as you, but just a different set of circumstances genetically, or however your body might have allergic reactions, etc. If we have a test that shows that this medication won't work, why are we going that route? You know, I don't want to increase the cost for everyone in this scenario, especially for the patient, but ER visits for reactions to drugs whenever we know they don't work. So that is predominantly the policy points of the Arthritis Foundation. We represent over 60 million Americans and the leading cause of disability in every single state. So when we talk about these issues and these access points, we're really not just talking about the cost and access of the drugs. We're talking about the cost and access for people to live their lives and go to their jobs and be able to work and play in their communities without having these barriers. And again, everyone at some point is probably going to have arthritis. So it's not an age-based disease, and is certainly one that we need to take seriously in terms of the cost to every part of our economy and communities. So that is mostly what I do. Of course, we work on prescription drug affordability boards as well, just again highlighting what the patient experience is. So if there is a prescription drug affordability board in a state, that we're making sure that patients are well represented, and that as pricing is considered, that we look at the full price. So if a drug is inaccessible or there is a price point, that patients don't have to travel to another state to get it, because in effect you've actually made it more expensive and harder to access by putting that pressure down on them with an upper price limit. So just really assessing the climate of what's proposed and trying to find the solutions that work from the patient lens is always our top priority.
All right. Can everyone hear me okay? Yeah, awesome. I think everyone broke out in cheers when Melissa said that they've passed this in 21 states. I think that was what the cheering was about, I'm pretty sure. So I'm Karenette Hinckley. I'm the Vice President of State Policy with the ALS Association. We developed a state policy shop back in 2022, so we're still pretty new. We cover all 50 states, and if my team can raise their hand here, they are working, again, across all 50 states as well as DC on the regulatory as well as the legislative side to really drive change at the level that really impacts patients living with ALS across the country. Not only that, but we secured a seat on the National Association of Insurance Commissioners as a consumer rep. I think it's the first rare disease seat that we've had on the Consumer Rep Council. And in that role, we are really focused on, to Melissa's points, utilization management, tactics, and how that locks people out of care. We're talking about ALS, a disease that when you're diagnosed, you're given 2 to 5 years to live. So delayed care is denied care, and it's a death sentence. We need to be able to access our medications when a prescriber says this is the medicine you need, or this is the device you need. Talking about step therapy and fail first, we're hearing from patients that they're being prescribed non-invasive ventilators, as an example, for breathing. And they're told they need to fail first on a COPD machine. I'm sorry, fail first with breathing is not an option for anyone. Also for nutrition products, we're told you have to fail swallow tests. Have you seen anyone take a swallow test and fail? It's horrific. This is not an option, it's inhumane, and my team and I are doing the best we can to really change the policies that we're seeing. You mentioned, Representative Kennedy, about the alternative funding programs and the AFPs, and we've been lucky to present to the Department of Labor on these policies and how they negatively impact patients. And yet employers are given information that these are helpful for people. It's very different. I think everyone here could raise their hand and say, let's bring down the cost of healthcare overall. Incredibly important issue. But how you do that without hurting the most vulnerable people is really important. So as it comes to PDABs and the prescription drug affordability boards, we understand how it can look good on paper and how, oh yeah, it sounds great, but it's not evidence-based. And I don't know about you, but in state policy, I like things to be evidence-based. I like for there to be data that's coming out that shows that the impact that this has won't be negative. Why aren't we seeing in the legislation requirements for studies on patient impact? That's certainly one of the provisions that we advocate for. The ALS Association, we don't have a position on PDABs, but if a state wants to run this policy, we want to be there at the table to talk about what are the provisions that will protect patients. So I think the RDACs, also that Representative Kennedy mentioned, are incredibly important players. If there's a state talking about PDABs, they should be talking with their RDAC. They should require a member from the RDAC to be part of that advisory board. As I mentioned, the patient impact studies. Let's talk about 18 months. Maybe 5-year review. What are we talking about as it comes to impact? It seems to me that what I'm hearing is, what are the cost savings going to look like? We're missing something there. Also, as it comes to rare diseases, I think we all know what has happened in Colorado with the PDAB and for the cystic fibrosis community. Again, locking people out of the one treatment that we know works. It's simply inhumane. So us keeping an eye on that in Colorado and in the other, 9 states, 10 altogether, making sure there's an orphan drug disease carve out so that folks that do only have 1, 2, 3 drug options aren't fearful that their lives are going to end because they can't access their medications. I could talk about this all day, but I know we're very short on time, and I think we wanted to open it up for questions. So I'll throw it back.
We are very short on time.
Yeah.
We're coming up on the final minute. And I know this half hour is always too short to talk about everything that we need to cover. But I wanted to really express to you that at the Rare Access Action Project and at our allied other organizations, that you have rare disease patients, you have professionals that you can go to talk about. As was just talked about, for example, there's no data around PDAB and the ability of PDAB to actually function the way it's articulated. We can help you find some of those areas where there may be solutions as alternatives to PDAB, such as capped out-of-pocket copays, alternatives to really help shore up the benefit and the coverage for the rare disease patient, because most rare disease patients will say, well, the cost to me is what I pay out of my pocket. And that's a very different discussion than the PDABs are having. And so
one thing I would like to say too, when she mentioned about the biomarkers and the tests that people are doing, it's a good thing and it can be a bad thing. What we have found is that in many cases, if that information is discovered and it gets out there, that individual could be denied health insurance coverage, life insurance coverage, simply because that is considered a pre-existing condition. So we need to tighten up this issue, particularly at the state level, to prevent this from harming individuals in the future.
Yeah, I would say security for all health data is also a priority. I mean, I think we all saw like information hacking just a couple weeks ago with like, you know, flying around the nation, all the blue screens. Like, even like our hotel here, like to check in, they had to go to carbon copy credit cards because their computers are still down. So it is a conversation with all of these issues, and always a priority that if we are doing testing or if there is other additional data collected, that data is protected. And that we don't go back to deciding who can live and who can't based off of what they've been diagnosed with. And I've personally experienced this myself as a 3-time cancer survivor, and I remember before the Affordable Care Act, I was uninsurable at 18, just from having cancer as a kid. So, you grow up with these chronic diseases, you shouldn't have to face all these barriers. Mostly we talk about cost, but access in general is always going to be a top priority, especially if there are challenges around like the expense of one individual. But really, we all save if it's all rising tides raise ships, every ship. So you want to make sure that if we're trying to help one patient, we're helping everyone. So whenever it comes to coverage, that we're being very inclusive with all of our language to protect data in general.
So I know we're out of time, and I would like to thank again the President Pro Tem of the Rhode Island Assembly, Brian Patrick Kennedy, for his comments and his leadership, both here at NCSL, in his state, and I know that he's become a resource for many other legislatures as well. I'd like to thank Melissa. Again, always a pleasure to be on a panel with you. And of course, Kara, for her insights into ALS. Now, they will be here throughout the meeting as well. You can find RAAP at booth 1151. I would like the RAAP team to actually stand up, because they actually help put these on and do a lot of work. And we have Mac in the back, who isn't even raising his hand at this point. But thank you to the RAAP team for helping us put on these events and for keeping the focus on patient access. This is really an important area moving forward, and we hope that you look at RAAP as your partner in this journey together. Thank you. And you know he's not.
I know.